Hi, good evening. My name is Dr. John Fallucca, and I want to thank everybody for tuning in tonight to this webinar that is sponsored by the Michigan Institute of Urology regarding prostate artery embolization and is prostate artery embolization right for you? Prostate artery embolization is a non-surgical option for treating BPH, or benign prostatic hyperplasia. Just a little bit of background about myself. I'm a board certified vascular and interventional radiologist. I am not a urologist. I graduated from Wayne State School of Medicine in 2005. From there, I completed residency training in radiology at Henry Ford Hospital. I then went on to subspecialty training in vascular and interventional radiology at Johns Hopkins Hospital in Baltimore. I stayed on at Hopkins for a period of time as faculty. From there, I took a job at the University of Wisconsin in Madison, Wisconsin, before returning back to Michigan and working at Henry Ford Hospital for many years. And in September, I left Henry Ford to join Michigan Institute of Urology and IR centers to offer these minimally invasive interventions to MIU patients. My specialties are what an interventional radiologist does is I specialize in doing minimally invasive surgical procedures using image guidance, X-ray, ultrasound, and CAT scan guidance primarily. Main focus currently with MIU and IR centers is prostate artery embolization treatment. We also do hemorrhoid embolizations. We do genicular artery embolizations in patients with knee pain from osteoarthritis. Our location is the IR Center in Troy. It's at 130 Town Center, Suite 203 in Troy, Michigan. So to start, what is BPH? So again, BPH stands for benign prostatic hyperplasia, which is often referred to as enlarged prostate. Important distinction to know is that this is not a cancerous problem. It is completely separate from prostate cancer. This is benign enlargement of the prostate. It is very treatable by many different methods and techniques, and it is incredibly common. As you get above the age 50, 50% of men will experience enlargement of the prostate. When we get to the age of 80 or more, 90% of men have BPH. And so why do men get BPH? And that's not entirely clear, but it is possibly due to changes in sex hormones as we age. So how does BPH affect your bladder? And so the bladder itself is basically it's a muscle. It's a hollow muscle that collects and then excretes urine. So urine is produced by the kidneys. It then goes down the ureter and into the bladder. When the bladder fills, the bladder contracts, and the urine will then exit the bladder out the urethra, which is basically a hose, and you urinate out the end of your penis. So how does BPH affect your bladder? Well, the prostate gland is a gland that sits just below the bladder and surrounds the urethra, exits the bladder. And you can think of the prostate almost like a donut. There's a hole in the middle, and that hole allows for the passage of urine. As the prostate enlarges, it starts to compress on that urethra. So you can imagine that if you're thinking of a donut with a hole in it, as the donut enlarges and gets bigger, you can imagine that hole gets smaller. So as that gets smaller, it becomes more difficult for the bladder to excrete the urine, causing the bladder to work harder and generate more pressure. It can lead to weakened stream and other symptoms related to enlarged prostate. If this goes on long enough, you can start to have issues with bladder function and potentially require catheter dependence over time. So the most common symptoms of BPH are the sudden and recurrent urge to urinate. You're having to go to the bathroom frequently. Difficulty starting flow. It can take a while for the bladder to build up enough pressure for you to excrete urine. Interrupted, slow or weak stream. Getting up at night to use the bathroom can be obviously particularly bothersome for most people. As the bladder has to work harder, it can, and you have to push or strain to urinate, it can become painful. And you can feel like you're not completely emptying your bladder. It can also lead to urine leakage. You can have either dribbling after urination or just incontinence in general. And that can be a result of two different scenarios. And one can be, you know, as the bladder has to work harder, again, the bladder is a muscle. So as the muscle, or as it works harder, the muscle will enlarge, get bigger. That decreases the capacity of the bladder. And it can make it so you're not able to store as much urine. Also, it can be something called overflow incontinence, where the bladder can fill. Because of the enlarged prostate, you're not able to completely empty your bladder. So you're starting already with a partially full bladder. So as the kidneys produce more urine, it continues to fill. And it can get to a point where the pressure and the volume within the bladder is so great, it overcomes your ability to hold that urine in. And so that can lead to incontinence. Some possible complications of BPH are urinary tract infections, because you're not completely emptying your bladder. One of the ways the body clears potentially infected fluid is by eliminating it. And if you're not able to eliminate it completely, that can lead to infection. So the urine is composed of different elements that, if remain stagnant within the bladder itself, can lead to bladder stones over time. If the pressure is great enough that it causes the urine to back up from the bladder, up the ureters and into the kidneys, it can lead to kidney failure over time as well. Again, urine leakage and incontinence that we discussed. And if this is unrecognized and not treated for a long period of time, the fact that this bladder has to work harder to compensate, to overcome the narrowing of the urethra, it can lead to bladder damage, loss of bladder function, potentially requiring a catheter dependence from that point on. Now, again, I want to emphasize that BPH does not at all increase your cancer risk. Those are completely separate entities. So there are 15 million men in the US suffering from BPH. It is a very common problem, as we discussed earlier. Now, 52% of men avoid treatment because they fear the side effects of that treatment. So how do we diagnose it? We diagnose it using various testing. The first that you're going to see the urologist, and they are going to likely do a digital rectal exam, which they would feel the prostate size and determine the presence of any lumps or bumps or abnormalities that may indicate a non-benign problem. Also going to check the PSA blood test. Okay, this will determine the cancer risk along, with the other tests. Now, in BPH, the PSA can be elevated. Urine tests, we're going to be looking for, presence of blood in the urine, as well as any presence of infection. We also do a bladder scan, something to look for what's called a post-void residual, where you do a scan, then patient urinates, and we scan the bladder again to see how much volume is left within the bladder after urination. And that gives us an indication of how severe the obstruction can be. So there are some higher, some more advanced tests that can be done to test bladder function. One is called a urocuff testing, which determines how well your bladder functions and empties. You urinate into this device that is pictured here, and it will generate some pressure, and the kind of pressure at which it stops the flow. It determines kind of the bladder pressure. So a little bit more invasive urodynamic testing is very similar to the urocuff. However, a small catheter is placed directly through the urethra and into the bladder to measure pressure and function there. Very important testing to be done to determine if BPH is the cause of your issues is to have a cystoscopy. So this can be done in the urologist's office. The urologist will take a camera, a scope, and they want to evaluate the urethra as well as the bladder. They can also see and determine what level of obstruction, how enlarged the prostate is by doing this. And it's important to have this done because in order to determine if the prostate is the cause of these symptoms, certain things need to be eliminated. There are different entities that can mimic an enlarged prostate. So narrowing or just strictures or blockages of the urethra can mimic those symptoms. Stones within the bladder themselves can mimic symptoms of enlarged prostate, as well as some tumors or abnormalities of the bladder. So it's very important for this test to be performed to determine whether or not BPH is the cause of your symptoms and whether or not a BPH treatment is the right thing for you. So another thing that we need or we want prior to this procedure and to help diagnose BPH is a transrectal ultrasound. So an ultrasound probe is placed into the rectum, and it is very, very good at determining the size and shape of the prostate. And that tells us obviously the degree of prostate enlargement, and it can help indicate sometimes which procedures or options may be better suited for each individual patient. If there is something on any of the testing that would indicate the need for a prostate biopsy, then that would be recommended. The biopsy would check for any presence of prostate cancer, and it's really only needed, again, if there's abnormality on any testing, significantly elevated, PSA or abnormal digital rectal exam, nodules seen on ultrasound, MRI, things of that nature. So we have multiple treatment options that can be done for the prostate. The least costly and least invasive treatment options are recommended first. And so what least invasive things can we do? Just general lifestyle changes can be done to help minimize symptoms. We can avoid certain medications that can exacerbate or worsen the symptoms of an enlarged prostate. We can then prescribe various medications to help control and mitigate the symptoms. And then from there, move on to procedures. So what lifestyle changes can we make to help reduce or eliminate the symptoms of BPH? First, you can relax, try to relax when you're voiding to help further eliminate urine from the bladder, and double void. And what double void means is you go, and then 15 to 20 minutes later, you go again to try to make sure that you completely empty the bladder. Avoid drinking liquids after dinner, which would help reduce the symptoms of getting up at night and having to wake up to go to the bathroom. Other things that we want to avoid because they can be irritants to the bladder and prostate are coffee, caffeinated beverages, coffee, tea, soda, alcohol, citrus, spicy foods, tomato-based products, and chocolate. All those can be somewhat irritating and stimulating to the bladder and prostate and worsen the symptoms of BPH. There are some medications in particular to avoid that can worsen the symptoms of BPH, in particular antihistamines and decongestants. So frequently in the fall and winter, or fall and spring, during kind of the peak allergy seasons, we can see some exacerbations of BPH symptoms as a result of people taking these medications. It's also important to be aware of over-the-counter medications that claim to help the prostate and bladder. So what medications can be used to treat patients with BPH? Well, there are really two kind of families of medications that are primarily used. The first is alpha blockers, and some common medications you may hear are Flomax, Rapaflo. And what those medications do is they relax the bladder and prostate muscles, which improve flow and allow more complete emptying of the bladder. Now, these do not shrink the prostate, they just help relax the muscles. The second class of medication is 5-alpha reductase inhibitors, medications such as Proscar and Avodart. Now, these medications can shrink the prostate by roughly 20% over a period of 6 to 12 months. So when do we consider procedures? So procedures can be considered and are recommended if lifestyle changes and medications don't work, or many patients don't want to take medications because they feel that the side effects are prohibitive. There's testing that can indicate that a procedure may be best, in which case we would consider and discuss procedural options. It's important to know that anytime we are considering a procedure, we make sure that we check with your insurer first. Medicare and most major carriers cover BPH procedures after copays and deductibles are met. So I'm now going to get into some of the surgical treatment options for BPH before we discuss the prostate artery embolization procedure in detail. Now, there are many different surgical treatment options out there. I'm only going to touch on a few of them, primarily those that are the most common. So the procedure that has been around the longest is called the transurethral resection of the prostate, or TURP. Many people affectionately refer to this as the Roto-Rooter procedure as well. This procedure is very effective at treating BPH. This procedure is done where the urologist in the hospital setting would insert a scope into the urethra and then use that device to scrape or remove prostate tissue from the inside. It is very effective. It is a proven treatment that has a durability of 7 to 10 years on average. Some drawbacks of this procedure are it can require a hospital stay overnight. Most patients require a catheter at least overnight, sometimes longer. It requires a general anesthetic, and there can be some side effects, particularly what's called retrograde ejaculation or dry ejaculation that can occur after this procedure. The next procedure that is done by the urologist, again in the hospital setting, is called aquablation. And aquablation is a procedure that is done using heat-free, powerful water jets to remove excess prostate tissue. So this is done by the urologist. It's robotic assisted. They also insert an ultrasound probe within the rectum to watch, and we have a video that shows this being done. So here you can see these powerful water jets that are removing the prostate tissue. And we can return to the slides now. So this procedure is also very effective at treating BPH. Has a durability similar to that of TURP, 7 to 10 years. Drawbacks potentially here could be, again, done within the hospital, potentially requiring an overnight stay. Likely you're going to have a catheter at least overnight, and it does have, because there is no ability to use cautery with this device, it does have a slightly higher bleeding risk as a result of that. The next potential treatment option is the Resume system. Now, this procedure can be done in the office as a minimally invasive procedure by the urologist. It is a procedure that, again, is also very effective at treating BPH, and it involves the use of water vapor to shrink the prostate. So the urologist, and we have a video that will show this as well, the urologist advances a scope into the urethra and then inserts a device within the prostate at different locations and injects water vapor. And we will play that video now. And so the scope, there's then a device that they can telescope out of the scope to inject this water vapor. The vapor then damages and destroys the prostate tissue. And this is done at multiple different locations in multiple quadrants to shrink the prostate. Once done, the device is removed and the prostate will slowly shrink and absorb over a period of 1 to 3 months. Again, this is another very effective treatment for BPH. Another treatment option that can be done as an outpatient in the urology office is the UroLift system. Now, the UroLift system is another transurethral procedure, a procedure that is done through the urethra, and it's basically like curtains to kind of pull the prostate back from the urethra. And this is done by putting anchors in throughout different areas of the prostate to compress the prostate and open that channel back up. And I'll show a video here of that as well. And so this procedure can be done, again, as an outpatient with minimal sedation, and is, again, a very safe and effective treatment. One potential drawback of this over some of the other procedures is the durability is not as long as the others. So this procedure, again, outpatient, sedation, and doesn't universally require a catheter. So there's advantages to that. Now we're going to move on to what we are here to talk about, which is the prostate artery embolization procedure. So prostate artery embolization, or PAE for short, is performed by an interventional radiologist. And it is done to reduce blood flow to the prostate, which causes the prostate to shrink in size over time, thereby relieving symptoms. Now, this procedure is not done through the penis. The catheter is not inserted into the bladder. This is done, for example, similar to a heart cath procedure, where I make a small poke in the artery at the top of the right leg. I then go up with a catheter about the size of a spaghetti noodle in the artery. I inject X-ray dye and I map out the blood supply to the pelvis. From that picture, I'm able to determine which arteries go to the prostate. I then get a smaller catheter called a microcatheter directly into the arteries to the prostate. And once there, I give these microscopic beads into the prostate artery, which block its blood flow. Now these beads, there's a picture of beads on the screen. Now those particular beads are actually much larger than the ones I use. The ones that I use would not likely be visible. The beads are 200 microns in size. They're incredibly small, and they lodge in tiny arteries within the prostate, which shut down blood flow to that area. And we have a video of this to show you the procedure. So the red tubes there that you can see are the arteries. And so I take a catheter up from the right side and go into the left initially. I get a smaller catheter called a microcatheter into the prostate artery and inject those beads, and the prostate will then shrink over time. I then take the catheter back to the right side because there is usually a single prostate artery on each side of the body. Once there, I repeat the procedure with the small microcatheter in the prostate artery and inject the beads, which cause the prostate to shrink over time. Now, in some patients, depending on anatomy or prostate size, there can be more than one prostate artery on each side. Now, when I do this procedure and I inject contrast in the prostate arteries, the prostate has a very characteristic appearance. So if I think that any portion of it is missing, I search for additional prostate arteries. And I will get into as many as I need to close down the blood supply. So following the procedure, the prostate will begin to shrink, relieving and improving symptoms. Now, it's important to know that this doesn't happen immediately. You will not leave the office feeling better. It usually takes 3 weeks after this procedure before you start to notice improvement. It takes that amount of time for the prostate to shrink enough to notice any change. Now, the prostate can continue to shrink for several months afterwards, so you can continue to have improvement out to 6 months' time. So this procedure, it takes, on average, about an hour, so 45 to 90 minutes. It is done in our outpatient office in Troy. It is not painful. The only part that is somewhat uncomfortable is usually the local anesthetic or lidocaine at the access site that can feel like a bee sting for about 5 seconds. After that, you generally don't feel anything. We give light sedation. Most people drift off to sleep and are surprised when we're finished. Once we're done, we take everything out. We bring you to our recovery area where you lie flat for 1.5 to 2 hours after the procedure. And when that time is up, you're able to get up and walk out. So the symptoms, as we said, will start to improve in 3 weeks, and improvement can continue over a period of several months. Now, some side effects that can occur, particularly within the first week, are a result of the fact that when we block the blood supply to the prostate, it can make the prostate a little angry, causes swelling and inflammation. And the swelling and inflammation of the prostate can cause symptoms that mimic a bladder infection or a prostate infection. So it can appear in some different ways. You can either have worsening of your existing symptoms, or again, it can feel like you have a urinary tract infection where you have to go more frequently, you have to go urgently, and you can have burning with urination. In most people, these symptoms are very mild, but in some people, they can be a bit more severe. Now, I can't predict who's going to have a more severe reaction, so we give everybody medications to take to minimize these symptoms after the procedure. Now, this procedure has an 85 to 90% success rate at achieving significant symptom relief from BPH. The average durability of this procedure is 5 to 7 years. So 5 to 7 years relief of symptoms from this procedure on average. And if you get a good response that lasts a number of years, this procedure can be repeated in the future. We also don't burn any bridge by doing this procedure. So any other procedure for the prostate, let's say you happen to fall into that 10 to 15% that may not get symptom relief from this, or at least not the symptom relief that you're hoping for. We've not burned any bridge. So any other procedure for the prostate that's available can be performed after this. In fact, it may make some of the procedures safer after this because by blocking the blood supply to the prostate, we eliminate bleeding risk. What are the restrictions after the procedure? There is no heavy lifting or straining for about a week after the procedure. And this is done primarily to protect the access site. I do use a device to close the small hole I make in the artery. It's basically a collagen plug or sponge that will dissolve over a period of 90 days. But anytime you strain or lift heavy, you increase pressure to that area, which can increase your risk of bleeding. So to be cautious and to be safe, we recommend no heavy lifting more than 10 to 15 pounds or straining for a week. I just want to point out that I do see several questions coming in, and I will get to those after the talk. So another common question that we receive is, what are the beads made of? And that depends on the manufacturer of the beads. There are 3 approved manufacturers by the FDA for PAE. The beads that I use are made of a substance called polyethylene glycol. It's basically a plastic, medical grade plastic polymer that are 200 microns in size. Other manufacturers can be made of hydrogel or trisacryl gelatin. These beads will stay in place. They do not dissolve. They are inert. They do not emit any radiation or chemotherapy, and they will not cause any issues over time. There have been no reports of any allergic reaction to these beads. Can beads travel to my heart or brain or cause blood clots? And the answer to that question is no, they cannot. Once these beads are in place, They are lodged within the artery and they cannot travel anywhere. So you can think of the blood vessels like branches on a tree. They start off bigger and they get smaller as you get out further. So these 200 micron beads are going to lodge within the artery when it is 200 microns in size. The artery continues to get smaller beyond that point, down to a point where only a single red blood cell can pass through it. So there is no risk of them traveling anywhere beyond the point where they're lodged. So do I still take BPH medications after PAE? And the answer to that question is yes. I want people to continue to take these medications for at least a few months after the procedure until symptoms have improved. At that point, if you've had significant symptom relief, you can discuss with your urologist, and they will usually start to slowly transition you off of those medications. And as you transition off of those medications, if your symptoms don't worsen, then they will continue to reduce the amount or the number that you take. Is there a risk from the X-ray exposure? And the answer to this is the amount of X-ray exposure from this procedure is negligible. I've done these procedures every day for nearly 20 years using X-ray guidance. There's never been any reported injuries or problems from the amount of X-rays received during PAE. So just to review some of the common BPH treatments, again, these are all very effective treatments. And I would never tell anybody which procedure is the best for them. That is a decision that is left up to each individual patient and their urologist and interventional radiologist. So to review, the most common, or the one that's been around the longest, is the TURP, the transurethral resection of the prostate. Advantages of that are it has a very long-term durability of 7 to 10 years and creates very good increase in flow rates. Disadvantages are, again, surgical risk, requires a hospital stay, frequently requires catheter for 1 night or longer, and almost universally leads to retrograde or dry ejaculation. And what that means is, again, the ejaculation goes back into the bladder, so nothing is produced out the penis. Aquablation, increased, again, significantly increased flow response, similar to TURP. This has low likelihood of ejaculatory effect, but again, hospital procedure with increased bleeding risk. The Resume procedure is another great procedure that is done in an office-based or outpatient setting. This has no impact on erectile function, can have some slightly shorter term results, and is limited to prostate size less than 80 milliliters or 80 grams. The UroLift, another office-based procedure, which again has no impact on erectile function, but can also have some shorter term results and some size limitations below 80 grams as well. Now, PAE is done in the office-based or outpatient setting as well. There is no impact on erectile function. There's no penile route of treatment. There's no upper limit on gland size. I've performed this procedure on prostates approaching 400 milliliters or 400 grams in size. Now, where we can have some limited effectiveness with prostate artery embolization is in smaller prostates, prostates that are below 50 grams or 50 milliliters in size. Now, if your prostate is below this size, it doesn't mean that we can't do this procedure and it can't be effective. However, that 90% number of symptom relief is likely reduced in smaller prostates. And if you think about it from a volume standpoint, right? So we get, after this procedure, on average, 35 to 45% reduction in prostate volume. The larger the prostate, the more volume reduction you are going to see. The smaller the prostate, obviously, the less volume reduction you're going to see. So that can somewhat limit the effectiveness in smaller prostates. Now, there are patients that have small prostates that I've done this treatment on as well, and have had very good results. As long as everybody understands that potential of symptom relief is reduced in a smaller prostate, and in some patients that are unable to tolerate general anesthetics or hospital-based procedures or on blood thinning medications, then we can consider this treatment option in patients with smaller prostates. Another disadvantage when you compare it to TURP is TURP has a durability of 7 to 10 years. This prostate artery embolization procedure has an average durability of 5 to 7 years. So advantages. Prostate artery embolization is a minimally invasive procedure. There's no surgical incision or no device inserted into the urethra. This is all performed in an outpatient setting under twilight sleep or sedation. There's no general anesthetic. It is a painless procedure lasting about an hour. Very low complication rate and no reports at all of impotence or incontinence after PAE. Symptom improvement begins to occur 2 to 3 weeks after the procedure and can continue for several months. And you can return to full activity with no restrictions at all after a week. So who is a good candidate for prostate artery embolization? Patients with a prostate gland that is 50 grams or 50 milliliters in size or more are ideal. There is no upper size limit. As I said, we can perform this in people that have smaller prostates, just with the understanding that the likelihood of symptom relief may be slightly less. This procedure is also very good at patients that have blood in the urine. There are many circumstances where the prostate is the sole source of blood in the urine, in which case this procedure can be performed and almost immediately eliminate the blood in the urine. This is also a great procedure for patients that have failed or do not want to take prostate medications, patients that are catheter dependent as a result of complete prostate obstruction and urinary retention, patients that want to have a procedure for BPH that want to preserve erectile and ejaculatory function as a priority, patients that are non-surgical candidates because they have comorbid conditions or other poor health conditions or are on blood thinners. Now, we can do this procedure as well on patients that have prostate cancer. And there are 2 scenarios in which we would do that. There are patients that can have low-grade prostate cancer that are just undergoing what's called active surveillance, where they're just being monitored, in which case we can perform this procedure on those patients as well. There are other patients that have larger prostates that are going to be undergoing radiation treatment for prostate cancer. And we can perform this treatment in an effort to shrink their prostate to help facilitate the radiation treatment by downsizing the gland. There are different types of radiation treatment. Some can be done over the course of several weeks, and some can be done over just 3 to 5 sessions. And in these shorter sessions, the prostate gland has to be below a certain size. So there are patients that we will do prostate artery embolization on prior to prostate radiation to shrink the gland to allow a shorter course of radiation therapy. We can also perform this procedure on patients that have had failed other transurethral therapies with preserved bladder function, or if patient's preference is to just not do transurethral procedures. So At this point, I'm going to answer some of the questions that have come across. MIU, we're very proud to offer PAE at our site, and I encourage everybody to talk to the urologist about the BPH treatment that is right for them. So I have a question here that asks if after a PAE is imaging recommended in order to see the actual size of the prostate. And the answer to that question is we don't routinely do that. Our marker for success is symptom improvement. So it is generally not necessary to repeat imaging if your symptoms are improving dramatically. So there is another question asking about having a 4-hour PAE 2 years ago. It was good for a while, but still getting up 4 times at night. Can you have the procedure again? And the answer to that question is yes, we can perform the procedure again. You know, it all depends on since you've had a PAE previously, I would want you to see the urologist, and we would likely do a similar workup again just to make sure that you continue to be a good candidate for the PAE. Patient had a TURP a year ago for BPH and still going every 2 hours. A new doctor also says TURP. He offered this procedure for discussion. Will I have better success with PAE? Answer to that question is it's hard to predict. TURP is very good at treating BPH symptoms. However, sometimes with PAE, we can, by embolizing the blood supply to the prostate, we can get some global prostate size reduction, and you may get some better symptom relief. Can I guarantee that? The answer is no. What are the sexual side effects? And the answer is there are no sexual side effects as a result of PAE. There is no negative impact at all on erectile or ejaculatory function from prostate artery embolization. Question about already having had aquablation therapy and results didn't change anything. Is this worthwhile to try? And I think based on the previous slide, patients, and again, back to the other patient that asked about the TURP, patients that have failed the transurethral therapies are good candidates for this. We can certainly attempt it. It's a minimally invasive option with extremely minimal side effects. So we can perform the procedure, and hopefully you will get benefit from it. Is the prostate killed? And the answer is the prostate is not killed. It's in its entirety. It doesn't become just kind of a gelatinous, necrotic dead organ. We block a majority of the blood supply to the prostate, but not its entirety. Portions of the prostate will die off and get absorbed by the body over time. And we get an average volume reduction, as I said previously, of 35 to 45% after this procedure. But the prostate does remain a viable organ. Over time, why the symptoms can recur like I said, after 5 to 7 years is new arteries, new pathways, channels will take over. And that is why we can then repeat the procedure in the future. What is the average durability for the water vapor procedure? That is a question that I will defer to the urology doctors, as that is not a procedure that I perform. It is likely very similar to the prostate artery embolization, but I don't have that exact number, so I do apologize for that. How effective is PAE for an enlarged median lobe? It can be very effective. Again, by blocking the blood supply to the prostate, we are blocking it globally. So we can treat all areas of prostate enlargement as a result of this. Can you have PAE if you've already had UroLift? And the answer is absolutely. I have performed PAE on many patients with UroLift. In fact, 2 of the 4 patients that I did the procedure on today previously had UroLift done. Can you cut off too much blood flow to the prostate? The answer to that question is no. Any artery that I can identify going to the prostate, I will embolize. It will still receive some blood supply from very small arteries that are not visible on our procedure. So like I said, it will still remain viable, just at a reduced size. What percentage of PAE patients require repeat PAE years later? And that is a very good question that we don't necessarily have the answer to at this point. Now, this procedure has been around for about a decade. And in the last several years, it's getting much more utilized. So we are starting to repeat this procedure on a handful of people. However, it has not been many yet, but I suspect that we will see more, in the coming years. But I can't give you an exact percentage of that number. I take Eliquis. Is the risk for bleeding? And so the answer is there's always a bleeding risk anytime you access the artery. There's slight risk of bleeding, but significant bleeding is extremely rare, much less than 0.5% of cases. On patients that are on blood thinners, if they can come off them for a period of time, we will usually stop them for 40 hours prior to the procedure and resume them 48 hours after the procedure. There are certain circumstances where patients are unable to come off their blood thinning medication, in which case we can consider performing the procedure on blood thinners. What happens to the little beads you use in this procedure? And the answer is they stay in place. They won't move. They won't go anywhere. They generally don't dissolve. Theoretically, could some of them break down a little bit over time? Potentially. And if that were to happen, they would just lodge in a slightly smaller artery. Does PAE depend on which lobes are enlarged? And again, the answer to that is no. Any driving restrictions after this treatment? We do not recommend driving within 24 hours, primarily because of the effects of the sedation medication. And then how long has this procedure been done? Yeah, it's been done for about a decade and getting much more widely utilized in the last several years. How widely performed is it? At MIU and IR centers in Troy, myself and my partner each perform 4 of these every day. So at IR centers Troy, MIU and Troy, we do 8 PAEs per day, every day. Can you go back to the work and office setting the day after the procedure? The answer is yes, you can. Now, if you were to have some of those small symptoms of worsening frequency, urgency, and burning with urination, you may not want to, but you can. Does this increase the risk of blood clotting? The answer is no, it does not. Understanding is PAE shrinks the prostate 30 to 35%. How many months does this take? So yes, on average, we get 35 to 45% reduction in volume from this procedure. You will start to notice the effects at 3 weeks, and you can have continued shrinkage of the prostate out to 6 months. Another question about does it kill the prostate, and we've already answered that. It does kill a portion of the prostate, but not its entirety. Does this process have any effect on the bladder, sphincter, and control? The answer is this procedure is done primarily to shrink the prostate. And so if the issues, if I'm understanding it, bladder, sphincter, and control, if the issue is of that of continence or incontinence, it certainly can improve that. And it improves that by shrinking the prostate, opening up the channel, the urethra, and allowing you to more completely empty your bladder. And by doing so, it should eliminate the risk of incontinence. Can it resolve occasional hematospermia, or blood in the sperm, which seems to come and go? The answer is potentially. The prostate does contribute to the seminal fluid, so the answer is potentially. How many PAEs have I performed? I have personally performed probably slightly over 500 of these procedures. Why does the PAE only last 5 to 7 years if the prostate is reduced in size? Does it start to enlarge again? And the answer is yes, it does. Because by blocking a majority of the blood supply, we do get that size reduction of 35 to 45% in volume, but over time, over the years, new arteries, new channels, new pathways will form, and the prostate can then start to grow again. And that can lead to a recurrence of symptoms over time. Had radiation therapy in 2019, but has been having hyperplasia, pain, and hematuria. Can PAE help him? The answer is yes, we can help him, especially if we know based on cystoscopy, they've ruled out other causes of hematuria, and it is suspected that the prostate is the source of the bleeding, then absolutely, we can help. Does it help with hydrocele? And the answer to that is no. This will not help with a hydrocele. And last question that I see here is, what do the beads actually do? The beads are inert. They're 200 microns in size. There's no radiation or chemotherapy. The way that they work is it is a mechanical obstruction of the arteries to the prostate. They lodge within the artery, blocking blood flow to the prostate, which then deprives the prostate of oxygen, nutrients, etc., which then cause portions of the prostate to die off over time. And that's how they work. Another question came in, do they interfere with imaging studies such as CAT scan or MRI? They do not. They will not be visible on any test that you have done in the future. So I think that is all the questions we have. I want to thank everybody for tuning in today. I hope this was helpful. There is a form that you can click on at the bottom to see if you're a good candidate for PAE. And our IR Center's number is listed there, 947-999-8244. Hopefully you got some benefit from this, and hopefully we can help you out in the future. Thank you very much.